Hello, Assalamu Alaikum. Welcome to another episode of Care Across Cultures. I'm your host, Mirban Hussain. We've got a wonderful guest for you today, and as I always say, all my guests are wonderful, and I'm incredibly grateful to all of them for taking time out to come to talk to me. So this is a show where we talk about what happens when healthcare meets real life. All of the stuff that the textbooks don't always cover, but what makes a real difference when you're sitting in a doctor's office. You are listening to Link FM, 96.7 FM. If you'd like to join the conversation, please call us on our studio hotline 0114 261 8181, or you can send us a text message on 07939 849 339. We'd love to hear from you. Whether you're enjoying the programme, enjoyed any other programmes, anything you'd like to say. Here's one for you. Maybe you want to come on the programme and talk about something. We'd love that to happen. So, before I sort of, go into the main body of the programme, there are some core messages I want to share with you today. So, the first thing is that if you have any issues, don't delay, because early detection saves lives. Most symptoms aren't cancer, but it's still worth checking it out. Most symptoms, and many symptoms, will have very simple explanations. But then again, you won't know until you get it checked out. There is free screening that's available for bowel, breast and cervical cancer. If you ever get a letter, please take it up. Because the survival rate at the early detection in stages 1 and 2 is 100% for many of these common cancers. And at stages 3 and 4 it goes down to 50%. GPs see these concerns on a daily basis. There's nothing that you can tell a GP that they haven't come across before. Very rarely, I think, and I have to qualify that, very rarely you're going to come up with something that they haven't seen before. So all of the opinions and views expressed on the programme belong to me and my guest, and are not necessarily the views and opinions of Link FM or of the organisations that I and my guests represent. So let me introduce you to my guest today. My guest today is Fiona Hendry. Have I got that right? Mm-hmm. Yes, I have. Hello, Fiona.
Hello.
How are you today?
I'm fine, thank you. Thank you for inviting me.
Oh, you're more than welcome. So, Fiona, let's start with a little bit about who you are, where you work, what's your job title, and then we'll take it from there.
So I'm Fiona. I am a consultant at Rotherham Hospice and also at the Rotherham NHS Foundation Trust, which is basically working Rotherham General Hospital as well as the hospice. I've worked at Rotherham Hospice for 20 years this October. I started there in 2005 as the first consultant, and my job was to sort of set up the consultant service. We just had a visiting consultant from Sheffield one day a week prior to that, and he persuaded me to apply for the job there so that he could go back to Sheffield, because he was trying to do two jobs.
So you were the first resident consultant
Yes.
at Rotherham Hospice?
Yes.
So you've seen a lot of history there, lots of changes.
So not obviously, the hospice had already been open for some time, but
Yes.
I was the first consultant and worked alongside the then medical director, Sue Wrigley, who was a GP as well as, so it had been GPs that had mainly been providing a service, and I was the first specialist in palliative medicine. And so when I started, had 3 parts of my job. I worked in the hospice, sort of looking after the inpatients. I saw patients within the hospital and saw people at home. And then over the years, it became clear that that's quite a lot to do for one person. And we've finally managed to persuade the then PCT, as it was, it's changed obviously now to an ICB, to fund further consultant, and now we have actually funding for 3 consultants, but we currently just have 2 in post and 1 due to start in October. And then that allows the 3 bits of the job to have a consultant each, so somebody for the hospice, somebody for the community and somebody for the hospital, which is all the places we deliver palliative care within Rotherham, where I work. To become a consultant in palliative medicine, at that point you could do training through general practice, which is what I did originally, before specialising in palliative medicine, which was another 4 years training. And I've worked in palliative care for over 25 years, initially in Leeds, Wakefield, Pontefract, Sheffield, Chesterfield and then Rotherham. So I've had quite a bit of experience across Yorkshire.
Fantastic. So you said that there are 3 consultants.
Yes, there will be.
How many other doctors do we have?
So we have, again, when I first started, we had very few. We had 1 doctor per day who was also a GP, so would come to the hospice, see the patients, go off and do their general practice. And now we have, say, 3 consultants. We have a trainee registrar, so who's learning to become a consultant, and they spend a year with us. That we've had 3 now, and we have specialty doctors, which are doctors that are no longer in training but have chosen to work sort of long term in palliative care, and we have several part-time but the equivalent of 3, and we also involved in GP training, so we have a GP trainee, because obviously GPs, part of their work is to provide support to people, their patients needing palliative care. Obviously it's a very big role of a GP, and we work alongside them obviously with their patients, so it's important that GPs have some training in palliative care.
So in terms of palliative care, and looking at all the different sort of specialities within medicine,
yes,
how sort of popular, if that's the right phrase, is palliative care at the moment across all sort of, you know, people wanting to be?
So it's become much more popular. I think, to me, and as I say, I've been a doctor since 1993. It's a specialty that still is able to provide true family medicine, in that you get to know your patients, their family. You're doing what I would call, you know, traditional medicine, which is talking to people, making an assessment of them, using that information, the information you find on examination, which is how I was taught as a doctor, and then you're resorting to tests and information that other things give you. Whereas now, particularly in hospital medicine, the talking bit comes a bit later, and we do all the tests and things on people first, and sometimes the bit of the interaction with people is lost a bit because everyone's so busy, it's so fast moving, that the bit about the talking to the patients doesn't get lost, but it's not necessarily as you're not able to do it, you don't have the time to do it.
It's not at the forefront
No,
anymore.
and I think increasingly doctors, you know, value that bit, and so they can see that that's possible in palliative care, because it's perhaps a little, not, it's going back to how things were perhaps 20, 30 years ago, maybe even in general practice, where we could do that. You could have the time to visit patients at home. Within hospitals you could sit and talk to them. So I think a lot of the younger doctors are choosing to work in palliative medicine because they value that.
Oh, right.
And so it's become more popular in my experience.
Is
We
that
have
personal interaction that
yes,
we're talking about?
yes,
Okay.
because you still, something that I won't ever give up is each patient in front of me gets what they need. They don't just get the time allocated, and of course time within all sorts of medicine now is very limited. And so when a doctor's having an interaction with you, they know they've got to get certain things out of you, and so perhaps it becomes less about what the patient's wanting and more about we have to have this information to make a decision. Whereas the interactions within palliative care aren't like that. They are still about, it's so much more about, these are the things what is it you want me to do for you? And I think that's the difference, and that's quite attractive to be still able to do that, which is why I think it's more popular than now.
Because there is this thing about building a trust
Yes.
with, a doctor-patient
Yes.
relationship and
Yes.
trust, because
And and that's the bit I like. I like to get to know my patients. I like to have that continuity of care. So, for example, I'm going to see 3 patients after this, all who I've known for some time. So I think, again, just because everything's got so busy in healthcare, that's much harder to do. We all know that it's, years and years ago you could see, you had your own doctor, your own GP, you would see your own GP. Now it's very hard to get appointments with the same doctor. So it's something that is very valuable and also allows you to see when someone's not right or things are changing.
So continuity of care that you're talking about with the same person.
Yeah.
And you're so right that I never get to see my own GP.
Yeah.
Some of us don't even know who our own GP is, in the sense that there might be 20 doctors there in your surgery,
Yes.
and you just get an appointment with whoever.
Yeah.
But continuity of care, I think, within a hospice setting, from my
Yes.
understanding, is something that's really, really
Yeah.
important. It's key. It's part of the holistic approach that hospices have.
Yeah. And certainly if you look within what we do within community, when you go and see somebody at home, you get so much more naturally more involved with them, because you're learning so much more about them than just if they come and sit with you in an office and you see just what they're presenting with. So to me, I mean, some people don't want that in medicine. They
Yes.
want it, if you were in some set, want it to be fast and furious and lots of, but it's.
Well, they
it's
could always
something-
go to A&E.
Exactly.
Yes.
Yes.
Yeah.
Yes. And so it's horses for courses, isn't
Yes.
it? But it's what I value, and I think the thing that's given me, obviously some of what we're doing is very sad, and we're seeing people through a very difficult time in that the people we see are not well. They have significant illnesses, but we hope that the only thing that we want to do is make that a bit better for them, and give them a better experience than if we weren't there. That's the only reason we do what we do.
That leads me on to something one of my GPs told me many years ago, was that it said, "Mirbank, tell me everything." These were the good old days,
Yes.
when it was more than 5 minutes that you could
Yes.
spend. And he said, "I want you to tell me everything." And I said, "What do you mean?" He said, "Every little thing
Yeah.
that you think is related to this issue, or you don't think is, and even if it's silly,
Yeah.
especially tell me the things that you think are silly." And that sort of led me on to an understanding that, because I was speaking with the GP, and they were talking about one of the first things that he learnt at school was look at people's fingernails.
Yes.
And I was so surprised to learn there's about 100 different
Yeah.
illnesses,
Yeah, yeah.
diseases that you can pick up just from fingernails. So when you talk about spending time, and when you talk about getting to know that person, especially in their own sort of environment, you're going to pick up on so many of the clues. Is it the case that often you learn more about a patient's illness, symptoms, from the things that they don't tell you?
Yes. And obviously the other thing about getting to know people is you start to know when things are not right, when they don't necessarily tell you that, and
Yes.
also they're more likely to tell you, you know, what's going on when they trust you. And you're in particularly in your own home, it's much less threatening. You're
Yes.
in their environment, they're in charge, whereas, you know, you look at hospital medicine, the doctors come round, stand at the end of the bed, talk to each other, and then they may talk to you. Sometimes, particularly if you're old and you're hard of hearing, you might not hear what they say. And it's, you know, busy wards, and then they're on to the next patient, and you know, again, so there's lots of reasons why you don't always get, you might not ask someone, so they don't tell you, but even if you ask, they may not give you the information because they're not sure, you know, what you're going to do. So it's very much about building trust, because
And that does lead me on to another question. We talk about telling truth,
yes,
especially to cancer patients.
yes,
And there is this a bit of a hurdle that we've got with some cultures
yes,
and some traditions.
yes,
The Western model says that, you know, doctors, we have to inform the patient
yeah,
of the truth. And then in other cultures, the family may not want.
yes.
So how do you deal with something like that?
So I think, again, that's about experience. You're right. Experience and reading things, isn't it? So I wouldn't say it is as black and white as that, because you get that in Western cultures as well, that families don't want you to tell patients, and you can get yourselves in lots of trouble by getting in the middle of sort of somebody saying you should say that thing and not saying the other. And so and of course you're right, it's added to maybe particularly when you're not sure if the patient's understanding you, because they may have a different language as their first language, and you may have to go through, you don't know quite what they're being told and things, so it's always very difficult. But I think, again, it's about, we would always check when we're talking to any patient what they understand first, because that's very, very important to know what they understand before we start saying this is what we are going to tell you. And again, in my experience, it's reading things, listening to them. Again, it's not necessarily culturally how we manage it. You know, it's whoever patient is, you read it, and you're also reading the family and seeing. And so, however, we have, you know, an obligation, if people are asking us questions, that we should answer them honestly.
Yeah.
I don't necessarily always tell people if they don't ask, so I don't feel obligated to tell people if they don't ask me things. And again, it's reading stuff, and you give them opportunities in different ways of seeing whether they want information, but also finding out what they really understand. And actually, often you can prize out with people that they know what's going on without saying anything, and then that, when you've prized that out of them, then that allows you to take that further if that's what they wish. So it is very much about having conversations at a patient's pace, not going too fast for them.
Yes.
And again, I think when you look at how things happen perhaps in hospital, or when you've got time pressures, we often feel we've got to say certain things and get certain things out. Again, the job I do means you can go back to things and develop relationships with people such that, you know, over time they trust you and will ask you things they may not have asked you when they first met you, or talk to you about things that when they first met you. And it's very difficult, because to give people true choice, they have to understand what the choices are.
Yes.
And if we keep information from them, or then they can't have true choice. So it is a dilemma.
It is a dilemma.
And it's a dilemma when families don't want you to hurt people, But you know, I've had many circumstances where a patient is telling me not to say anything to the family because they don't want to hurt them.
Yes.
The family are telling me the same thing, and I just say, well, you do, you both know.
You both know what.
You know, obviously, in a you know, in a more so, and you know, it's trying then to get them together, isn't it, to talk about it? Yeah.
Right. Okay. I want you to share with me, if you will, a particularly difficult situation in the past sort of 20 odd years of this kind of thing, where you've had to sort of, where the patient was saying, don't tell my family, and the family was saying, don't tell, you know, and how did you sort of manage that? What did you actually
I think
do?
you know, it does happen, and because obviously you learn the tricks of the trade, and actually the difficulty you sometimes have if you tell families first before you've told the patient. Now clearly some patients aren't able to engage because they may have conditions that either mean they're too unwell, or they have cognitive problems like dementia, you know, where they can't understand, and then obviously you would be talking to the family. But in most circumstances you would make sure you get both, you know, you offer the opportunity for people, particularly when you're saying bad things, to talk to each other together. Now, most people know that if you're saying, I'd like you to bring your family in, that it's not necessarily going to be something good that you're telling them.
Yes.
Because you wouldn't wait for a family member to come before you said something good. So then they can say, oh, you know, no, I don't, you know, so you end up telling them. Then the family come later, and I mean, I've had one recently where the patient said, I'll tell them, I don't want you to tell them, and then didn't.
Right.
So the family then come several days later when they do find out, and are very upset. So you know, those are all reasons why it's better to talk together. I think it is very difficult when there's a language barrier, and again I think you are then relying on family to tell patients things, or interpreters, and we've had some instances with interpreters where the interpreters have got very upset and felt they couldn't talk to the family about what, you know, the patient about what we were discussing. So it's not always the answer to have somebody separate, or someone who's perhaps impartial, because obviously that's an added complication, and you know, particularly if you're with families and then someone's talking in another language, you're not sure obviously what they're saying.
Obviously, it's, that's another issue. I think, you know, we might touch on that later if we have some time. If you just joined us, you are listening to Link FM, Care Across Culture, with me, your host Mirban Hussain. I'm talking to Fiona, who's a consultant over at Rotherham Hospice, and we're just going into a short break and talk soon. Assalamu alaikum, welcome back to Care Across Cultures with me, your host Mirban Hussain. You're listening to us on Link FM 96.7. Our studio hotline, if you'd like to get involved, is 0114 261 8181, or you'd send us a text message on 07939 849 339. I've been talking to Fiona Hendry from Rotherham Hospice, who's a consultant there, and actually the first resident consultant in 2005, I believe. Is that correct, Fiona? 2005. And you've been there ever since?
Yes.
Fantastic, thank you so much. We have been talking a lot about Fiona's background, a lot about what sort of palliative medicine looks like now as opposed to what it was before. But I know that Fiona has some specific interests, and we will now be talking about those. So Fiona, the thing that I want to start talking about is that you have a special interest in non-malignant palliative care.
Yes.
So before you start, what is non-malignant?
So I think traditionally and palliative care was always seen to be something that was related to cancer, which is obviously malignancy, and it's still, I would say, within healthcare, within the general population, its belief is it's a lot to do with cancer, and of course it is, and we do a lot of work with people with cancer, but there are obviously palliative care needs. That's people who have advancing diseases with a lot of symptom issues, which can be physical, psychological, social, etc., which is all the things we deal with in palliative care in all sorts of disease. And the one I particularly work with, and we work very closely with Breathing Space, which is a centre in Rotherham specifically for people with respiratory disease. So Breathing Space obviously tries to improve and does a lot of rehabilitation for people with respiratory disease, but they also look after people with more advanced diseases such as severe chronic obstructive pulmonary disease, so COPD, and conditions called like pulmonary fibrosis. And within this area, which obviously there's been a history of smoking, which contributes to those diseases, and also the heavy industries within this area, and
mining and
yes.
coal and steel. Yeah,
exactly. So those predisposed to respiratory conditions. So I work closely, and
I just want to stop you
Sorry.
one moment, sorry, because I'm just aware that some of my listeners may not understand some of the terminology that you've used. So respiratory, what does that?
So that's diseases of the lungs.
Okay.
So obviously the effects of that are usually impacts on your breathing and being breathless or short of breath, cough, etc. Those sorts of things are the symptoms that people deal with.
So you mentioned COPD and asthma. Is asthma also?
Not so much asthma, because
Okay.
asthma is a disease that can be managed. So
Right.
and it's the diseases that are those more difficult to manage, or we manage alongside the treatments like inhalers or medication to try and slow down the disease. Within the things that we do are about helping people to manage when those treatments are not necessarily helping so much now. So it's people with those more advanced diseases.
Okay. So, and I also want you to, I want to understand a little bit more. You said advanced disease.
Yes.
What's the difference between, why do you use that terminology, and where's the sort of cut-off point?
Because it's where it's maybe having a very, very significant impact on somebody, and they're struggling to manage with the symptoms. So the patients we tend to see are those that maybe are housebound because they're so breathless. They struggle with the just normal activities, we call them activities of daily living. So that's just things like making a cup of tea, having a shower, going upstairs. Those sorts of things are things they struggle to do on a day-to-day basis, and what we try and do is help them to do more, or help them have a better quality of life. And I think these patients are sometimes quite unseen because they don't tend to go out, because obviously we're saying that they can't do things within the house, so they struggle to go out, and so we're not seen so much, and we get referrals from the services that look after them usually from Breathing Space, where they're seen as patients regularly, seen they have more problems, and they want us to help them to have a better quality of life, which is what palliative care is trying to improve quality of life.
And I wanted to sort of pick up on a point that you made in terms of palliative care, because a lot of people that I've met in the communities, and I've mentioned palliative care, and it's always sort of linked to cancer.
Yeah.
But from what you're telling me, it's not just cancer.
No, absolutely not. No.
Can you sort of explain a little bit more about that, what palliative means, and why it's not just cancer with the other?
Okay. So palliative care is the definition is about people who have advanced progressive disease, where you still may be having some treatment for that to try and slow it down. So in cancer, chemotherapy, or other conditions, you may still be having treatment to try and slow it down, but the symptoms and the impact of that is having a significant impact on you. So like I've just explained, advanced respiratory disease, you're still having input from people who, when you have an infection, you'll have some treatment, you may need to go into hospital for oxygen, but alongside that we're trying to improve things for you, and I think palliative care tends to manage symptoms that can't be changed. So you have a problem like breathlessness that the respiratory teams have tried to address, but are struggling, and then they're asking us to do something alongside them. So I think that's the other thing, is people think you have treatment and then palliative care because there's no treatment any longer, and that's not true. We work alongside and support, and some of the people that I've looked after who've had respiratory disease, I've known for many, many years. I have a lady recently who I looked after for 8 years, not seeing her all the time, but I've been involved in helping her, and she used the hospice 8 years ago, and then used it more recently as she became more unwell. So I think there's a misconception that it's all about the end, when it's actually about it's all about helping people to live better.
And I'm so glad you mentioned that, because there is this myth out there that hospices are places where people go to die.
Yeah.
And yes, it is true for some people at end of life. But you mentioned life, it's about living, and how do we help support you to carry on?
Yes, absolutely.
Which is more positive, isn't it?
Yes. Yeah.
So that's sort of taking the fear, I suppose, away.
Yeah.
It's not the end. And also, hospices are also places where you can just go for symptom management.
Yes.
And pain relief.
Yes.
And you can stay there, for a week, 2 weeks, or until your symptoms and your pain has come down, and then you can go back home.
Yes.
Yeah.
Yes, absolutely.
Yeah. So just because you've been referred to go into a hospice does not mean that you're at end of life.
No. And I mean, again, like I said, whatever we're doing, and that's true at the end of life, but obviously true is we want to change the experience of somebody, so it's better. The only thing I ever want to do is to improve people's quality of life, and that's why the only reason we sit and talk to them, why we try and change anything, why we try and suggest things, is about helping them to live better than if we weren't there.
So you've said something there that's suggesting. Yeah. So there is maybe a misconception out there amongst many communities that a doctor tells you what to do.
Yes.
Okay. Yeah. And there's a bit of a forced thing. Well, this is what you're going to do, and this is what I recommend, and this is what we're going to do. But from what you're saying, that's not the case.
No.
In terms of.
You would give options, and clearly the whole point is that we're an expert, and we would say we could do this. This might be the good bit of it. There's bad bits of it, or we could do something else. And it's allowing people choice. And I think particularly when we know that maybe someone isn't going to get better, the best we're going to do is change things a bit for them. Then we use expressions like there's burdens and benefits of treatment. So these are the things that might help you, but this is what might be the consequence of that. And then we look at any treatment and say, so some treatment might be that you have to spend a week, 2 or 3 weeks in hospital. But then there's a burden to that because nobody particularly wants to spend 2 or 3 weeks in hospital if they don't have to, and particularly if your time may be limited, it's about thinking about, is that really what you want to be doing? So it's much more about discussing with people choice and understanding what it is they want. Because most people want to not be in hospital, they want to be with their family, and it's about balancing that.
Personalised care.
Absolutely.
You've just described it perfectly. Now, I do know that you've got some specific interests.
Yes.
Learning disability, palliative care.
Yes.
So if we could have a discussion about that, chat about that. First of all, if you could define learning disability, what that actually is for our listeners.
Yeah.
And then why you're interested in that, and let's have a chat about that.
So learning disabilities, obviously those people who have needs that affect their ability to understand, and it's a massive spectrum.
Mm-hmm.
So from very profound and multiple learning disabilities where everything they have needs to be sort of managed by someone, everything that happens to them it needs to be anticipated by someone else, to those with fairly mild just need more support with understanding things. And the reason I suppose I have particular interest is because I have a son with profound and multiple learning disabilities, so naturally I've kind of wanted to think about improving the palliative care or the care for those patients. And I think those are the patients that particularly struggle in a hospital environment, so where it's much more alien, it's much more difficult to personalise the care for them. They often get put on a ward which they don't understand what's happening, and a lot of patients with learning disabilities, depending on the severity, may live in homes where they're supported by carers, or by live in homes where, specific learning disability homes. It's about trying to provide care in their setting, and then very much supporting the people who are looking after them, who have no experience in palliative care, because it's better to have the people who are familiar with you looking after you, who've known you for maybe years and years and years, than importing new people, particularly when it's difficult sometimes for them to gain the trust of that patient, because I suppose similar to what you were saying, doctors can come and poke them and prod them and often do nasty things to them, and they struggle to trust them. So it's very much about supporting them again to be in their own environment, whether that's their own home, with their their families, or with the carers. So we invest a lot of time, and this is something I try and really advocate for, is about how we support and give the support to the carers, or their normal carers, to provide the support as with their palliative care needs. So we don't necessarily, and the hospice does this alongside me with the nurses that work, so they're getting care in their own home and not having to come somewhere else which is alien or unfamiliar to them. We do sometimes have people in the hospice, and then obviously we encourage the carers to come in alongside them, but mostly we're trying to deliver that in their settings, and we've done that, I think, quite well. I'm visiting one of my patients that I've known for 2 or 3 years, where we're working alongside his residential setting, and they, as long as you're providing lots of guidance and trying to anticipate things and really support them when they need you, we can be very successful at doing that. And I think it's something that we've done several times. As again, like I told you, I work in hospital. At the moment, probably half my clinical time, or more than half my clinical time, is in hospital, and it's not a nice environment. They try. It's not, and we have specific learning disability teams in hospitals, but it's it's not. You just can't give that personalised care.
No.
And it's in the same way for anyone who perhaps doesn't fully understand what's going on. It's scary enough when you do understand what's going on, but then to sort of add perhaps that lack of understanding, or lack of really understanding what someone's doing to you is an added thing. And
it just seems to me that with learning disability, you've already got a condition, a health condition that you may have had for life so far.
Yes.
and then all of a sudden, you know, you've got other added things, because
Yes.
just because you've got learning disability doesn't mean that, you know, you can't get cancer.
Of course. Yeah. Me. Yeah.
And then you end up with some kind of cancer, and mix in with that another illness, so multiple
That you don't necessarily understand as well the
that you
impact
don't-
that's having on
so
you.
you're already
yeah.
having difficulties with
Yeah.
something, that,
Yes.
and then you've got 2 or 3 other things added on.
Yeah.
And as you said earlier rightly, that with lots of people with learning disability who are
Mhm.
affected by learning, routine is something really important to them, isn't
Yes.
it? Yeah.
Yes. And the people they know,
And the people they know.
I mean, we have things like hospital passports where people write everything down and say this is what so and so likes and doesn't like, and this is how the best way to explain things to them, and they go into hospital with them, but they sometimes get lost along the way, or people don't necessarily read them. So in my experience, trying to keep them out of hospital when we can, and
Is the
clearly we
best
can't
way.
always,
Mm.
and certainly again when we see patients in hospital, we try very hard to get them out as soon as we can to an environment that is they're familiar, you know, which we do for everybody, but I think it's more important. And again, there is ways of talking, you know, understanding, giving people information, ways they understand, whether that's written, you know, and again, getting to know somebody. So so this patient I'm seeing now has known me for 2 years. He trusts me. I'm not just someone who's coming along, to do something bad to him, and I can also know, because I know him, I know how he's changing and the things that are different, those sorts of things.
Yeah. So one of the key things that I've picked up is this building this relationship,
Absolutely.
because we're talking about palliative care,
Mhm.
and now with palliative care, my understanding and also what you've said is that it's not necessarily a short-lived thing.
No,
It
no.
could be years,
Yeah.
or tens of years even,
Yeah.
depending on at what age you've been diagnosed and
And what condition you have.
what condition you have.
Mhm.
So building that trust and that relationship with
Mhm.
people, with your carers, with your medical nursing staff, is really, really important. Which is a lovely thing to think about then, but then I'm looking at some of the challenges that we might have
Yes.
when staff leave,
Yes.
because staff do leave.
Yes.
Yeah. And then that's going to have a huge impact on
Yeah.
that person, and then maybe building. I suppose in an ideal world what we could do is if staff do leave, but when we know that they're going to leave, is there something that you do within the hospice where you can start to introduce another member of staff?
Yeah.
Or
Yes, and I suppose realistically most of the patients we look after we're not looking after for years. So, and sometimes we're coming in and out of their conditions, so we may be getting to know them, doing the initial assessment, and then working alongside other services, because with the best will in the world I don't think there's any palliative care service that's able to provide, you know, has the funds or finances or staff or personnel to do you know, that for years, and we would love to, but it's just not realistic. So it often is working alongside other services and dipping in and out. But you're right, certainly I think particularly for people with learning disabilities. So I think more recently we had a patient where myself and one of the nurses took the lead in his care, and we attended meetings about him, etc. But obviously other nurses had to be involved and support. But you know, we got to know him, and then obviously other people were involved. So it's never perfect, but we try.
And I think that's the main thing, isn't it? We try. Now, we are coming close to the end of the programme, so if you've just joined us, you are listening to Care Across Cultures on Link FM 96.7 with me, your host, Mirvan Hussain. I've been having a wonderful conversation with Dr Fiona Hendry, who's a consultant at Rotherham Hospice. And we've had a very wide-ranging conversation today about lots and lots of things. we talked, Dr Fiona talked a little bit about her reasons for becoming a doctor and a consultant, and the specific areas that she wanted to specialise in. There is still time if anybody wants to send me a text message about a question or anything. Before I go back to Dr Fiona, I just want to mention a few things based on what we've talked about. So one of the things I want to say is that family support is a strength and not a weakness. If that's what your family is, and this one, that's a strength. Confidentiality is an absolute thing. If you don't want us to tell anybody, we won't tell anybody. If you have any persistent symptoms, anything that's just, we often talk about a cough. If you had a cough, I've got a cough. But my cough is just a remnant of my own personal cancer journey. If you have a persistent cough for 2 weeks or so, you need to go and see your GP. Please take up any screening invitations that you get. And please remember that, at these appointments you can take a family member, a friend, and if you need an interpreter, ask for an interpreter, because it's a right that, and you will be provided with one. And this is a personal favourite. Please don't Google it. Okay? See a professional. There's lots and lots of professionals. We've been talking specifically about Rotherham Hospice, but there are hospices across the UK who offer similar, if not the same, services that Rotherham Hospice offers. There is one near you in the town that you live. Reach out to them. There are other organisations, services, healthcare organisations. Reach out. Everybody's got a GP, and that should be your first place of call. I'm going to go back to Fiona now. Fiona, we have literally only got about a minute or so. What's the last sort of message that you would like to give our listeners today?
I mean, I've sort of mentioned it a couple of times, but what we do is about, what I do, and the reason I go to work every day is to improve people's lives for however long they have, and that might be a few days, it might be years. That's the purpose of palliative care, and so I don't want people to feel scared when it's suggested. We don't do anything that shortens people's lives. We do things to enhance what life they have, and that can be very much alongside other treatments, so please don't be scared. We only want to help and to make things better for you.
I'm going to leave it there with some wise words from Dr Fiona. Don't be scared. Reach out for help. Inshallah, I will be back next week with another guest. Allah Hafiz. Until then.